We pooled patients from 10 different centers internationally and looked at patients for whom they had gotten checkpoint blockade prior to TIL, ultimately progressed following checkpoint blockade, got TIL treatment, ultimately progressed, and then got some form of checkpoint blockade again. So that was the patient population. We have response data for 96 of those patients. And what we know, unfortunately, is that we only saw 7 responses out of those 96 patients. 6 of those 7 patients were actually rechallenged with a different regimen than they got before TILs. And so what this tells us, is that we don't necessarily get this big reinvigorated T-cell response that checkpoint blockade can rescue. But that may give us information about what to do with our standard of care patients who do progress following TILs. For example, if a patient got nivo-ipi prior to TIL treatment and progressed, perhaps that might be an opportunity to treat them with nivolumab relatlimab. And in fact, our longest responder on that clinical trial, or this patient cohort, had exactly that scenario, had been treated with nivo-ipi before TILs, and then had this ongoing durable response to nivolumab plus relatlimab. The other really important piece of the data is that checkpoint blockade after TILs was safe. There was no increase in toxicity, no unexpected toxicities related to the checkpoint blockade. In fact, 70% of the patients had no reported toxicity at all. And so this opens up, potential other options for patients for whom TILs did not work. We need to really start thinking about including these patients in refractory trials because we're going to see more and more of them. They need to be included in checkpoint plus trials that we're seeing in the refractory setting. And this provides some safety data that tells us that that may be possible.